3, 1. Good morning from Miami Beach. This is Dr. John Bennett, Neurosurgical TV. We have the honor of having Vance Lehman, MD, and interventional radiologist from Mayo, as well as having another couple other projects. And he's going to talk about his book, Unlocking Success in Medical Training, with mastering the hidden curriculum. Well, okay, welcome, Vance. It's all yours.
All right. Well, welcome. It's a pleasure to be here. Thank you so much for hosting me. I do have a presentation today, so I will just share my screen and we can kind of walk through that. Okay. So, all right. Is everybody seeing this screen?
Yeah, perfect.
Oh, okay. So, yeah. So I've got this book, Mastering the Hidden Curriculum. I would like to discuss this concept today. And to start, why is this a concept that we would be interested in? Why did I write about it? Why am I interested in it? And what's the target audience for this project really? Well, it turns out that there's a lot of unspoken factors that profoundly influence our personal and professional outcomes, and they're all related to this thing called the hidden curriculum. And by the end of this webcast, I hope to make a good case that successful navigation of the hidden curriculum is a key determinant of our success. So we'll come back to that at the end. How did I get interested in this? Just briefly, I came across this concept of the hidden curriculum only a few years ago, several years out of training. And I was wondering, why had I not heard about it before? And as I started to look more and more into it, it really started to resonate with me. And I started to realize that were just so many things that I wish I had known earlier in training, and I wish other people knew as well. Um, After doing some more research, I found that there really wasn't a single resource out there that was comprehensive, um, and really explained that topic as a guide for medical trainees. There are some books out there that are more academic, but I didn't find a guide. So I felt compelled to write it. When I started to write the book and tell some of my friends in other departments and other institutions about it, I started getting emails and correspondences every day with examples of things that they that should be included in the book or things that they have observed. And usually those resolved around professionalism and generational perceptions of trainees. Those are by far the two biggest ones, but also uh, the third most common one is why are trainees not reading as much anymore, and what else can they do to use more effective learning strategies? So the target audience for this project is really, I made it broad. I thought long and hard about how to do it, but medical students and residents just in general. But really, the concepts could be useful for people across their medical career. These are a lot of things that I didn't discover until well after training. I wish I would have known sooner. And I think these are things that we can all use, regardless of what we're doing, medicine or even outside of medicine, really. So I'm going to start off with questions. You don't have to actually answer them, but we'll go through these fairly quickly. And throughout the presentation, we'll kind of answer these questions and we'll come back at the end and see if you can kind of quiz yourself and see if you can get them right. First question, what are the four main types of curricula? Second question, formal lectures on professionalism mostly offsets the effects of observing unprofessional behavior by attendings or peers in the clinical setting. Is that true or false? Can you give formal lectures to offset these effects? Which of the following are different types of mentorship? Formal versus informal, challenge versus supportive, peer versus superior, research mentor, or all of the above? Who spearheaded the first modern U.S. surgical residency? You'll see why this is relevant later. Was it William Halsted, William Osler, Charles Mayo, or Walter Dandy? What percentage of a subjective performance evaluation is noise? Is it 25%, 50, 75, or 89%? This answer is based off of, and all of this is evidence-based, by the way, and the references are in the book. This is based off of Daniel Kahneman's book, Noise. True or false? We learn more from our own failures than observing those from others. True, false, or it depends. Here's a hint. Usually in medicine, if one answer is it depends, I found that that's usually the right answer. Um, okay. Which of the following is generally considered an effective learning technique? Rereading material, highlighting keywords in a book, mnemonics, or content creation? Generational perceptions are influenced by which cognitive bias? The Dunning-Kruger effect, which is related to overconfidence bias, fundamental attribution error, hindsight bias, or the illusion of moral decline. And what percentage of medical students in the US have a physician parent, at least one physician parent, which is the best answer? 10%, 25%, 50%, or 75%? And final slide, which of the following is usually most effective in gaining access as a trainee to hands-on procedural experience? Planning the procedure ahead of time as if you were the sole operator, bringing notes that demonstrate that you have planned the procedure, knowing the evidence, indications, alternatives of the procedure, or assuming your chief or attending can just sense your level of interest. The sum percentage of perceived effort to a group project is closest to what? Now, this is perceived. So obviously the real group effort is 100%, but if you have 4 people and each person is rating what they think they're contributing, what's the sum of that, of those numbers? Is it 90%, 110%, 140%, or 200%? And finally, the null curriculum refers to topics that are unimportant, outdated, intentionally left out, or scored as pass-fail. All right. Oh, I guess I do have one more slide. The hidden curriculum has is which of the following is true? Has a well-established consensus definition, was first described in the medical literature, is a sneaky way educators try to trick and test you, was first described by name in the 1960s. The difference between an average writer and a great writer is most likely natural gift, years of experience in medicine, attention to editing, doesn't matter that much in medicine. On clinical rotations, first impressions, or elsewhere in life, first impressions are quickly forgotten, less important than last impressions, reliable ways to determine if somebody is trustworthy, or disproportionate influencers on the opinions of others. Okay. So we'll come back. It's a lot of information, but we'll walk through that and come back to that at the end. So it turns out that when we learn, there are 4 major types of curricula. People use different terms for this, but this is kind of the most common way of look at it. There's formal, informal, null, and hidden. So formal is what you usually think of when you think of a curriculum. It's acknowledged and structured. So you may have written learning objectives. Informal is something that's also acknowledged but less structured. So a good example would be teaching on medical rounds. You expect that you're going to be taught on rounds. It's not fully structured, but it is expected and acknowledged. The null curriculum are things that are intentionally left out of a curriculum because you just don't have time to teach everything. So those are intentionally left out. They're acknowledged, but we're not going to teach those because we don't have time. Then the hidden curriculum represents things that are unacknowledged and unspoken, and it's got kind of a little bit of a more in-depth definition that we're going to come back to in a second. But before we come back to the definition of hidden curriculum, it's important to recognize that these 4 types of curricula are not as distinct as I just made them sound to be. There is some overlap and the boundaries can blur. So for example, the formal curriculum it overlaps with the hidden curriculum in a few different ways. One is the medical training in general is usually better at giving us a lot of information than teaching us how to learn it all. And that's really important, is how do we learn it all? So because we have this extra challenge of learning it, of having a bunch of information thrown at us, but we're not given tools to learn it all, that can be considered by some people to be a hidden challenge and part of the hidden curriculum. Just how do I master this mountain of material? Also, in medical education, you may find unintended messages embedded within formal materials. For example, if you're giving a case, a hypothetical case scenario, a patient presents with X, Y, and Z, what treatment are you going to prescribe? What treatment are you going to do? If it's worded that way, it's very different than what treatment would you recommend after shared decision making. So some people argue that just the way we word things in the formal curriculum can imply subtle subtext and implications for, is there paternalism? Are there stereotypes in there and those kind of things. So there is some overlap between the formal and this hidden curriculum that we're about to come to. The null curriculum is super interesting because, there's a lot, obviously we can't learn everything. Medical school has already got way too much information. We can't learn everything medical, and we certainly can't learn all these things that are non-medical. But if you look at these things, these non-medical parts that are topics that are usually, not always, but usually de-emphasized. You may learn a little bit about these in medical training, but I would argue usually not enough, right? Statistics, logic, negotiation, leadership, conflict resolution, and managing people, writing, and editing. So the reason why this could blur with the hidden curriculum is just because these things are not formally taught and they're not formally stated in the formal curriculum doesn't mean that they're not beneficial or useful or rewarded when you know these things during training on the rounds. So it's a kind of a hidden challenge that we have to try to pick up on some of this stuff without so much formal education. For example, trainee may make too much of a they may find a paper to support a decision. They want to make a treatment recommendation for a patient. They find a single paper with a p-value less than 0.05 on a single unreplicated study and make too much of that because they don't really understand the pitfalls of p-values and one p-value just because you have one example that's less than 0.05 doesn't necessarily make it true, and oftentimes they are not true. So that there's a lot with statistics, and a lot with logic and negotiation and all these other things. I find that the managing the difficult people and navigating personality differences are some of the most important things I do, but yet I wasn't formally taught. In writing and editing, often not formally taught in training, but yet some of the most important things we do because this is a major way we're communicating our thoughts and helping treat patients. And we're judged by this. We're judged by it, but we don't get a lot of special training. And very few people enter medical training with a good ability to write. And it turns out that if you ask good writers, like professional authors, what the difference makes, yeah, there's some natural ability in this and that, but mostly it has to do with practice in editing, looking at other things that are similar topic and trying to emulate it, and then spending a lot of time editing. So excellent authors spend a lot of time editing, and I think we could do more of that with our medical work. Stephen King in his book On Writing says, to write is human, to edit is divine. So how can we manage all of this when we don't have time? Like people are working 80 hours a week, there's already too much to know. Well, I would argue, first of all, you can't learn it all at once. But it's a kind of a career-long project to learn all these things. I'm still learning all these things, but you can start and you should start earlier. And one thing the book tries to do is it gives you a better head start on a lot of these topics, and then you can start integrating them into your practice a little bit sooner. So I think that's really useful. These are the things that I find much more useful than a lot of the things I learned in my formal classes, to be honest with you. So that's the null curriculum. So then there's this concept called the hidden curriculum. I'm not sure how many people have heard of this here before. Again, I only heard of it a few years ago, but I do get a lot of questions when I started writing this. It's like, it just seems like there's definitions all over the place. I don't really know what it means. It's something that's not, it's hidden, it's not well defined. But what is it and where did the concept come from? So we do have to do just a little bit. I won't spend too much time in history because I want to get into the good stuff, but it is kind of important to understand where it comes from. So people have been talking about it for a long, long time, but the first time that the term was used is usually acknowledged to this person, who's Philip Jackson, who's a sociology education researcher who wrote this book in 1968. When he was writing this about primary school, this wasn't about medical school. So this comes out of the primary school education originally. And what he noticed was yeah, there's a formal lesson plan or formal curriculum teaching math, grammar, geography, science. But then what kids are really learning in addition to this are all of these other things. It's what he calls the daily grind. People learn that they get up, they go into work, they learn about authority, they learn about interacting with other people, they get a sense of where they belong in society. And there's all these other forces and socialization that's occurring that's not part of the lesson plan. So then he described that as being a hidden curriculum in for primary school. After he did this, several other researchers followed suit and started to look at the hidden curriculum from a lot of slightly different angles. And that's where the different definitions come out. And then people eventually started looking at colleges, and then in the 80s or 90s started looking more at medical training. And now there's been a proliferation. There's just too many papers actually in medicine if you start looking for it. But this is where the definitions got a little muddy. So people are looking at kind of similar concept from different angles. So there's three kind of different major angles you can look at it from. There's the socialization angle, which is what I was just talking about. Daily grind, you learn how to, understand hierarchy and peer interactions, and how to, in medicine, it's how do you act? What are norms, culture, and that kind of thing. Then there's also rewards and incentives is another thing. So this often has to do with things are rewarded or praised that aren't formally acknowledged. For example, you may have a medical training program that says we value problem solving, and active application over rote memorization. But if all their tests are A, B, C, and D, what they're really testing is rote memorization. It's a mixed message. Same thing with individualism versus, a teamwork. Everybody says we value teamwork, but if your institution is only giving out rewards or awards for like teacher of the year or to individuals, what it's really teaching, according to hidden curriculum, is individualism. It says one thing, but it's another thing. So there's all sorts of these rewards and incentives. Or somebody might come through and be praised for skipping lunch every day that week for taking care of patients in front of the whole team. Well, that's sending the message to the whole team that you should really skip lunch. So that's another aspect of it as well. And you can see how that is actually one just kind of special case of like trying to modify people's behavior. It really is related to socialization. Then finally, there's a social sorting perspective where people are nudged into a certain direction for their careers with signals. So maybe before medical school, people may get certain signals that maybe they should become a physician or shouldn't be or should not go into that route. Or when somebody's in medical school, they may get certain signals that maybe they're a good fit for a surgeon or a pediatrician. And some of those signals might be like, well, why would you go into radiology? You're such a good people person. You should use those skills. But that's usually given to women, not men. So that's a social sorting sort of thing. So that's another aspect. So there's all these aspects of the hidden curriculum, but there's socialization, rewards, incentives, and social sorting. So that's where it gets a little confusing. You can also look at it from the perspective, are we looking at interactions between people, trainees and teachers, or are we looking at the system? The system and all three have an impact on our outcome. But that's just one more layer of complexity. Is it the institution or system or individual interaction? So just to put that out there too. And finally, where people start to get really confused is they say, well, hidden curriculum now, there's been such an explosion of publications that it just become a wastebasket term, because I see one where it's just talking about hidden curriculum of professionalism, hidden curriculum of spirituality, hidden curriculum of first generation, hidden curriculum of malingerers, and it goes on and on. Yeah, I got some examples here, but there's dozens, probably hundreds out there, right? So it's everything under the sun. But I think what this is these are just special cases. And really, they're just special cases of the overall concept. So I think if you get too bogged down in the hidden curriculum meaning one specific thing, you're kind of missing the big picture. So how can we make sense of all this in a definition? There's different definitions out there. It's not one consensus definition. So to make a manageable functional definition for this book, I just defined it as unspoken expectations, invisible challenges, and stealth influences. But what really matters, though, I think, is just recognition that there are unspoken factors that profoundly shape our professional and personal outcomes. I think that's more important than the exact definition. And I think also what I chose to include in the topic is the test is it important and useful? Is it something that's kind of hidden from us, and is it useful for us to know about? So that's what it kind of boils down to, in my opinion. Okay. What's the evidence for, under the impact of the hidden curriculum? Well, despite the proliferation of a lot of papers, if you dig deep in the medical literature in the last 10 years or 15 years, um, most publications that are specifically looking at hidden curriculum medicine are still descriptive. They're based on self-report. They're small. So it's a good start. They're good papers, but it's not super robust. And I think that reflects the fact that we're talking about a complex topic in a complex environment. It's really hard to study, but that doesn't mean that it's not impactful. First of all, we have anecdotal experience, and some of it's based on experience, but there's also a lot of robust evidence in a lot of other really closely related areas. I've got listed here: effective learning and psychology and complexity science and so on. So what I do in this book is these things are not studied under the name of hidden curriculum, but they're completely related. So we take all the evidence in all of these things as they could relate to the hidden curriculum and kind of compile that together. And I think that this is the first, book or project that has really done that. So that's what I think is really useful. So there is evidence. It's just kind of, you don't want to be bogged down as, are they calling it hidden curriculum or not? Okay, so to understand, I make the case in the book to understand the hidden curriculum, we do have to understand it is useful to understand a little bit about human history and evolution. And why is that? Well, evolutionary psychology really goes a long ways to explaining workplace psychology and behavior. If you understand this, it makes a big difference in understanding what's going on around you, in terms of in-group behaviors. And we have lots of in-groups in medicine. People are this specialty or that specialty or this hospital, that hospital. And it really helps make sense of what's going on around you. Also, understanding hierarchy. Uh, Understanding hierarchy is what and navigating that well is one key determinant of success in the medical system. We have to understand the physician hierarchy, how hierarchy works with nurses and all of that. But uh, really historically and through our history, humans have been relatively egalitarian. We developed and we evolved to be cooperative, and we didn't have lots of belongings. We were nomadic and that kind of stuff. So the hierarchy grates against some of our natural tendencies, which is just normal. So it's useful to kind of understand that when you're kind of going through something that's very hierarchical, like medical training. How we learn for 2 million years or more, we've learned basically how to use tools and hunt and things like that from watching and mentorship and doing, and then eventually storytelling. So it was experiential learning. We didn't learn from books. We don't really have a reading center in our brain, really. So that I think that's useful to understand too. And then finally, there's a lot of talk these days about well-being, and there's a big perspective that we're kind of misplaced cave persons. We're genetically similar to how we were 40,000 years ago, but yet working in the hospital is nothing like, what we've been like historically, and that explains a lot of our lack of well-being these days. There are some counter viewpoints to that, but I do think it's useful to understand. So kind of jumping forward here to 1900 to 2025, 1900 LA versus 2025 LA. 1900 LA obviously looks nothing like what those cave people experienced. But there's been a huge change. What a difference 100 years makes between 1900 and 2025. Throughout history up to this point, 100 years didn't make much of a difference. 800 AD versus 700 AD, not that big of a difference. But now we've got this big difference. And why does it matter for the hidden curriculum and for educators? Why do we care about this? Well, what happened in 1900? We'll come back to that in a second. But first of all, the big things that have changed over this 100 years is there's lot more things that vie for our attention and our time and energy. So I'm not going to go through these in detail, but basically the world today is a lot different than it was in 1900. We have a lot more and different stressors and things that are really taking our time and energy. But what happened in 1900 was, well, just before 1900 was this physician. And who is this? I don't know if anybody knows who this was, but this is William Halsted. He was one of what's called the Big Four at Johns Hopkins, and they started the first residency programs there. And he was the first program director for surgery. He started the first U.S. surgical program, and that still has a big influence on us today. So he was a kind of a privileged individual. He had gone over and studied in Vienna with Bill Roth and came back and he spearheaded a lot of great techniques and mosquito forceps and local anesthetic. But tragically, he became addicted to cocaine because he was experimenting with cocaine local anesthetic. And that is thought to be one of the reasons for his development of the all-encompassing residency program. So his residency program was highly successful. People had, graded responsibilities. It was 6 years. He lived in the hospital, 3 days off per year, but it was also thought to be partly a cover because he became addicted to cocaine and then later morphine. Um, so that's just kind of a little bit of history that's interesting. But obviously, the residency that we had back then doesn't really work all that well in 2025 because there's been all of these changes, right? And of course, yeah, there have been some work hour reforms and some other changes to medical education, but still, this is really where our residency program comes from. So I think that's important kind of history to keep in mind. But of course, back then they didn't have pagers and lawsuits and all these other things. We've got a lot of other stressors and demands in our lives now that they didn't have. All right. So with that backdrop and the hidden curriculum and the history and how it's changed over the last 100 years, both in general society and within medicine, we talk about 6 central strategies to manage the hidden curriculum in the modern environment. One is you have to get the easy things right. So it turns out that attendings will be pretty forgiving if you don't know something that's hard. If something's difficult, you don't know it in your training and you're early, that's expected, but you got to get the easy things right. Basic professionalism things and knowing your patients well. If you don't do that, you're in big trouble. Use effective learning methods, we'll talk about. Be proactive. You can't just wait for the system to do good things for you. You have to go out and seek opportunities and seek mentorship. You have to understand how others think, and that means knowing a little bit about psychology and personalities and common beliefs, but also recognizing that everybody is an individual and kind of surmising what any individual really believes, especially people who are evaluating you. Recognizing influences so you can determine which ones to embrace and which ones to resist, and then challenging yourself appropriately. It shouldn't always be easy if you're going to do well. Okay, so effective learning strategies. There's a huge amount of literature on this, and this is one of the areas of feedback that I got that trainees could do better. And I can't go into detail on every single technique here, but there are some common patterns I think that we should recognize. So common traits of effective learning strategies. They're active, so you're participating instead of just watching or listening. Watching may be fine at first, but eventually you have to do it to learn it. It's effortful, so it pushes your limits. Something could be active but easy. This means that it's also difficult, just at the edge of your limits or just beyond. It's purposeful, so it considers goals, timing, and importance. So this may include things like spaced repetition or taking things, you've got all this information and how am I going to learn it all? Well, you can take things and put it in different buckets. So this is super important now because it's things that I'm going to be tested on or things that are life-threatening or things that are common and things that are like, okay, I need to know a little bit about this, but I maybe don't have to have it at my fingertips. I'll have it where I can look it up. And you have to use high quality resources. So not just like don't jump straight to the review books is one thing I see is people jump straight to the bullet point review books, or they go and internet is full of great resources, but they just find random things on the internet and it's kind of a patchwork. So you have to be kind of careful with that. It has to be meaningful, tie it into existing knowledge. It has to be relevant and interesting to you. This is one thing where mnemonics fall apart, is mnemonics usually aren't interesting or aren't meaningful to you usually. So most of the time, research has shown that mnemonics actually result in accelerated forgetting. So they're actually very counterproductive in most cases. There are some effective ways to use them, but you have to be a little careful. It has to be specific. So, if you're going to learn to do brain surgery, you don't spend all of your time doing surgery on the abdomen. It's similar, but you have to be specific. So eventually you do have to be specific. And experiential knowledge in the clinic kind of covers all of these. So I think that's really important. Other things that are useful is teaching and along with teaching at the time, doing content creation. Those things are effective. Rereading and highlighting and those types of things, or just looking at review books and just reading those, without context, less useful. And then finally, it's social. This is how we've learned throughout human history. There's just so many unspoken things and things you can't really put into words that you can only learn by watching how other people do things. So effective learning is social as well, and that requires being present in person. So professionalism, this is one of the big areas I got feedback from that, could be issues for the modern trainee. And, surveys show that people are hired for ability, but fired for professionalism issues. And that's true. And that's where trainees usually get in trouble, is for stupid professionalism issues. Talk a little bit more about that in a second. There's evidence that shows if you're not professional, you don't have professional if you have some lapses in training, that predicts future problems when you're out of training. That's true. Um, and there's also research that shows is if the people around you are acting a certain way, you can give them all the lectures you want. They're going to do what they see, not what they're told. That's a big take home here, is you can tell people things all that you want in the formal curriculum. You can write it down, you can give them lectures, but they're going to really be more likely to do what they see, not what they're told. In training, professionalism is judged during times of high stress. So this is really common, is it's usually on call and you're pushed to your limits and you feel like this, somebody's inner Napoleon comes out. But that's almost a surefire way that you're going to have an instant email or other communication right to your program director. So during times of high stress, you have to really try to put that aside. Just recognize that a little bit of intermittent stress is just expected. It's a good time for growth, and it'll be done. It's just temporary, and think about the big long-term picture, and not definitely don't let your inner Napoleon, because you won't get the same benefit of doubt as maybe an attending does when you're a trainee. You will. This is one way where people go down. And then there's some evidence that professionalism, unfortunately, can decline during training. There's some mixed results on this. There's actually some mixed controversies over empathy declining. People say, oh, empathy declines during training. And it's true. But there's also different types of empathy, and there's cognitive empathy, affective empathy, and then there's compassion. And some people will say, well, maybe it's a good thing, although it sounds terrible, that your affective empathy is a little bit better regulated, because if somebody's in a lot of distress, a patient, you don't want to show a lot of distress, because that will just cause them to be concerned. You want to keep a cool head, but you do want to show compassion. Okay, so there's basic professional expectations. This seems so easy, but this is where people tend to go wrong. Just arrive on time, prepared, polite, positive, appropriate attire. I hear about sort of like, though they wore a baseball cap to radiology sign out. That's not like, why would he do that? But these are the types of things I hear about. And stay until the workday is done. You would think that people would just know these things, and I think attendings just assume, it's just too obvious to even to call attention to. But these are areas where people they often stumble a little bit, and maybe it's because people haven't had a real job. Maybe that's part of the reason why. But it's pretty common. So you got to get this right. This is like getting the easy things right. Okay. First impressions, again, this is like work from Daniel Kahneman and others. They make a much bigger impact than a lot of us realize, right? So maybe it's not right, but it does. So whether it's your first day on a rotation or anywhere else, if you make a positive first impression, what happens is the attending will have they'll try to create a coherent narrative. So it's a psychological bias called excessive coherence, where we want to make sense of the world around us. So we take whatever little information we have and we try to make a story. So if we just have a little bit of information, oh, this student's doing great, we're going to tell ourselves a story. Oh, it's a great student, right? And then in turn, the interactions between the attending and the student sends positive signals, and it creates this cycle. And this is a well-described psychological phenomenon that first impressions matter a lot, and they matter more than they really should. And then after that, what happens, you've got a coherent negative narrative and it's reinforced, is the attending then will likely go and tell all of his other attendings who are then like-minded. So then a first impression then amplifies this way too. So this is just one one example of how one small change, arriving the first day with a positive attitude, on time and prepared, can have massive downstream effects, more than you realize. So that's part of the hidden curriculum here, is just making little tweaks can have big outcome differences through like kind of like a butterfly effect. Of course, the opposite can happen too. If you have a negative first impression, you give negative interactions, you get a setup fail syndrome, and then you have downstream negative effects, and that can happen. And of course, you can overcome a bad first impression, but it's a lot of hard work. Now, the counterpoint to this is, if you're the person doing the evaluation, try not to be overly swayed by first impressions, because we know that they are more impactful than they should be. And also, some people tend to give, this is only 1% of the population, but the people who tend to often give the best first impressions are sociopaths. So you have to be a little bit careful about first impressions, but try to make good first impressions yourself. Okay. Other big topic besides professionalism, when talking to a lot of attendings, were just generational trends and labels, and this is a big topic. This is a very common uh, topic of conversation. So, who is this? This is Hesiod. He was a poet in Greece in 700 BC, and what did he do? He complained about the younger generation. They don't have good work ethic and all of this and that, right? And this, of course, is Bob Dylan, says the times are changing. In that 1964, people are still complaining about the younger generation. So times are changing, but maybe the people aren't. So what's going on here? Most experts agree that our generational labels and perceptions are, the negative stereotypes are greatly exaggerated due to a cognitive bias called the illusion of moral decline, which means when you judge a younger generation, you're judging them by your current self, not your former self. And that's just what we psychologically tend to do. So if we're judging people based on our current self, we'll tend to say, oh, they're not being as responsible as I am today. But you forget what you were like, 30 years ago. So that's one thing. But that said, there are some really important things to note here. About 2 years ago, there was a really interesting podcast on New England Journal of Medicine, about this topic, a series of topics. It's called Not Otherwise Specified, that I'd recommend everybody listen to that too, where attendings really explore, and students explore the topic of generational trends and labels. And what they found was that a lot of things there's a perception that a lot of things that were considered routine just, 20, 30 years ago in training are now considered harmful. So things that were considered beneficial routine are now considered harmful. And there are a lot of perceptions out there by modern attendings that a lot of people in the younger generation are, they just don't have the desire to be in the workplace as much as they should, because that's how you learn, are and just are not as receptive to feedback. That would be the other thing. So people are now afraid to give feedback to the trainees because they're worried about, negative repercussions. So these negative perceptions are pretty pervasive. Not everybody has them, but it is a good thing to be aware of. And what you want to do as a trainee is to offset those as much as you can. So the way you do that is you make a good first impression, you follow those basic expectations, and then you ask for feedback, and make it safe to give people feedback, because these generational labels, it's a really big problem, and it's something that you want to try to preempt when you're the person being judged. Okay, leadership and management, we get very little of that in training, but it's really important to understand the difference between the two, which I'm not going to go into today, and traits of excellent leaders. The traits of excellent leaders are different when you're talking about a CEO of a big company versus a small team leader. A small team leader, which is more relevant for us, is going to know their team members well, set clear values locally, set clear roles and expectations. That's a big part of trying to overcome these hidden expectations that are around us, is make it clear what you expect. And then learn to manage failure. So it turns out, and there's good research on this, is that we think that we learn a lot when we have a failure. You have a failure, you think you learn a lot. But it turns out that people tend not to learn a lot from their failures, because very often, what happens is people get defensive and they deploy ego defense mechanisms and they don't really listen, especially if somebody's giving them feedback about their failure. They just shut it off. So people often learn more from watching other people's failure. So that's a good reason to share failure in a safe way. But you can learn a lot from your failure, but it has to be managed in a way it's safe. And so if you're managing other people's failure, you have to normalize it and make it a growth opportunity. Otherwise, they're just going to shut off. And that's a big thing in medicine and professional growth. I think that escapes us. Promote teamwork. That's important. So it's got to make it clear that it's not a zero-sum game. Um, and also recognition, make it clear that, there's individual recognition, sometimes that's warranted, but there's also team recognition. So if you're going to say for teamwork, you have to give team recognition, not just individual recognition. And also acknowledge the fact that people on the team often feel they're working harder than it might seem to you. So you might think somebody's not working hard, but they probably feel like they're working harder. So the Harvard Business Review did a study that showed that the net sum of perceived efforts in a small team is going to be 139% or 140%. Obviously can't be more than 100%. But the take home point is everybody feels like they're doing more than they actually are. So that's just something that's good to be aware of. Then, of course, you have to lead by example. If you're not willing to do something yourself, at least at some point, then other people aren't going to want to do it either. Mentors, sponsors, and role models is at the heart of the hidden curriculum. So if I were to do one thing differently, if I could go back in time, it would be to more proactively seek out mentors and sponsors. It's super key, and it's for career development. You can see in the corner here, this is the first mentor in Greek mythology. Is Mentor is his name, who is tasked with mentoring Telemachus with Odysseus as he went to fight the Trojan War. So that's where it comes from. But the types of mentors, this is really key because every institution is different. So if you're going to try to figure out how to navigate your own personal situation, you need mentors from the place that you're working, right? And there's lots of things that come up all the time that you just can't find answers to in a book. And people have wisdom that you can tap into. So there's different types, there's formal who are assigned and informal who, you just find on your own. And they're both important. They both have a role. There's also challenge versus support. Challenge mentors will challenge you to be better, but they might be a little critical of you sometimes. Support, they're going to have unconditional regard all the time. And there's maybe some role for both of those as well. Mentors can come from all different levels. Okay. You're going to want some mentors who are well advanced and ahead of you for sure, and ones that don't feel threatened by you and they're just there to help, but also some that are just a year or two ahead of you as well. That's also super important. And I think people forget that. And then research mentors kind of like its own thing. Another thing, a big mistake in medicine and elsewhere, very common, is people assume that a mentor of theirs is functioning as a sponsor. But often, if you're behind the scenes, you notice they're not really actively functioning as a sponsor. They don't even think to do that. So a sponsor is somebody who's actively advocating for you. A mentor is there to guide you, but they may not go and go to bat for you. Sponsor is somebody who's actively advocating for you. And you can't just assume, like if you do a research project with somebody, like, hey, they're gonna vouch for me for this fellowship position or the staff position or something like that. Sometimes they do, sometimes they don't because they don't think about it. So if you want somebody to be a sponsor, you really have to know them well, know that they're on your side, and have a discussion with them to see where they're at, because otherwise it might not be happening. And I think both are useful. People who tend to get places tend to have mentors and sponsors advocating for them. First generation physicians is another important topic. There's a lot of structural forces, at least in the United States, that really segregate our applicants and really make it so that most of our incoming medical students are from middle or high income households. And actually between 30 and 44% of medical students have at least one physician parent. It's kind of a wide range. It's hard to get exact numbers. So I put it kind of in the middle, about 25%. So why does that matter? Well, it matters for a few reasons, but one is first generations are disproportionately come from underrepresented backgrounds. So it does have that effect here as well. And first generation medical people in medical school. There's less data on this than there is for college, but they report an increased risk of imposter syndrome and adversity. And of course, that's not good for learning. Sometimes there's conversations about, vacations and socioeconomic status that they just find make them uncomfortable. They have to divert the conversation or avoid. Once in a while, sometimes there's financial concerns, not always. But most importantly, they don't have built-in mentors or role models at home. So they're figuring things out from the start very often. So it's important if you're a first generation physician to be aware of these things, to learn a lot of the stuff I'm talking about, the hidden curriculum, really, that I'm talking about today, and to really actively seek out mentors, role models, and sponsors. And also, just hearing the fact that somebody tell you, like, hey, you belong here just like everybody else does, I think that's useful too. So there are some challenges for people who are first generation physicians that I think are useful for us to all be aware of. Feedback's an important one. You don't know what people think about you if you don't ask for feedback. It turns out, and this really kind of shocked me, but subjective performance evaluations are up to 75% noise. I mean, I knew that they were pretty unreliable. In medicine, there's other evidence that they're unreliable, but mostly they're error. At least according to Kahneman, and that's not in medicine specific. So I'd like to think we do a little bit better than that, but it's kind of a problem because our most important evaluations in medicine are subjective because we get written feedback, we get letters of recommendation, and there are clinical rotations. But you have to understand that there's a lot of variability in that. So what we want to do is to try to diminish that error as much as possible, and that just comes with having a good working relationship, I think, with your staff and asking for feedback and asking for expectations. If you don't do that, you're really just leaving it up to chance. Um, it's important, as I mentioned, due to generational concerns and concerns about the current environment. Some attendings are hesitant to provide feedback. They think there could be retaliation. Uh, some are even concerned if there's like really negative feedback, they could be at risk for a lawsuit. So obviously, people are not going to be giving feedback if there are those concerns. Um, if you're getting feedback or giving feedback, it's important to make it normalized so it doesn't seem like, oh, I'm getting feedback, I must be in trouble. It's just something that you routinely do. So you tell people at the beginning of the day, we'll give feedback at the end of the day, like we do every day, and give feedback and make sure feedback is different than an evaluation. People will respond better. Like, I'm just getting feedback to help myself grow. It's not my final evaluation. That is useful as well. Another message I'd have for all of us, but especially for trainees, is when you're behind the scenes, you see that you cannot easily predict who is going to be an easy and tough grader, right? Some of the people who are just the nicest people, they're a game show host, they're your best friend, are the toughest evaluators. And some people who are the most stern people and just gruff are, they're just doing that for your best interest, but they're actually nice evaluators, or they don't fill out an evaluation at all. So you can't predict. You can't predict. You've always got to be on and just this, don't try to think that like, oh, they're an easy grader, so whatever. You just don't know. And we have to receive and provide feedback effectively in medicine. If you seem like you're resistant to getting feedback, you're probably going to be in a lot of trouble. Okay. So finally, in the book, we go into some specifics about outpatient, inpatients, learning procedures, and just a few things about the procedure since we have the neurosurgery audience here. One thing I hear, and I work closely with a lot of our neurosurgery trainees here and a lot of the radiology trainees, is most attendings spend more time preparing for a case the trainees realize. So if you really want to get into a case, you got to really probably spend more time than a lot of people are doing. So you have to prepare as if you're going to do it solo, start to finish. Obviously impossible when you're just starting out because you don't know everything, but do as much as you can. And the other thing that really helps is especially when you're new and haven't worked with somebody much, is show clear, visible evidence that you prepared. So that often means writing it down on a piece of paper or something that they can show you, because an attending might not have time to go through and ask you and quiz you to see if you really, really prepared. But if you can just show really quick that you did it, that goes a long ways. And I hear that from surgeons, interventional radiologists, from all sorts of people. So that's a very useful tip. Obviously, you have to know the indications, risks, alternatives. If you're not knowing these things, there's a good chance your attending just won't let you touch the needle in radiology or do much at all with the procedure. Remember that procedural memory is different. So when you first start with a new motor skill, you're using your you're using your working memory a lot more and rather than your cerebellum. So it's slow and clunky, and that's just normal. So a lot of people underestimate their ability to do procedures long term because they're starting off slow and clunky, and that's just normal. So with time and practice, it can become more automatic. Um, and sometimes, you do have to be proactive about doing a procedure, but sometimes it's more appropriate to observe. Things that are complicated procedures, you have no chance of doing it. You're just learning about the procedure. So that's just kind of a fact of life there as well. Okay. Final message I'd have before we go and revisit this is there a litmus test that, if you're working with an attending that they will use to say, was this a good day? Was this a bad day? Is this a good trainee? It's a bad trainee. It's a good evaluation or a bad evaluation. Um, Obviously, there's no single litmus test, but if there was a one, this is what I would say it was. An attending could ask themselves, was my day better than it would have otherwise been? Now, that doesn't necessarily mean easier. If you're working with somebody who's new, you don't expect it to be easier. In fact, it will probably be a lot harder. You'll probably have to take time to explain things and work longer hours. But if they're prepared and interested, and you think you're doing good and teaching somebody, that's really rewarding. And that's better than it would have otherwise been. If a trainee's experienced and should make it a little easier for you and they're doing the basics, then yeah, was my day a little bit easier in those regards. That's important too. But that is really, I think, what it kind of comes down to is was my day better than it would have otherwise been for having worked with a trainee versus working solo? Okay, so that's kind of a lot of information. I know some of it's some background academic information, but I think it's really practical and useful. And so, why would I argue that the hidden curriculum is a major determinant of success? Well, the formal curriculum has important gaps that are things that are still useful and beneficial and things we're still evaluated on. And it doesn't tell us how to fill it in, related to the null curriculum. And understanding the intersection between the null curriculum and hidden curriculum can help with that. Medical training doesn't always teach us how to manage a mountain of information. It's just one gap that it has. And that's one thing here, understanding with the material I'm talking about today can help with that. Our professionalism is primarily driven by role modeling and observation and things that are more closely related to hidden curriculum. We can give formal lectures, but they don't really make as much of a difference. So how we act and present ourselves is something that's from observed behavior. The hidden curriculum is adaptable to different settings. Okay, for example, it represents what attendings really expect, not what they're told to expect. So somebody who's evaluating you, yeah, they can fill out the box. Even if you try to give them boxes to fill out and try to make it objective, they can fudge that how they want to. They're gonna basically do it based on what they want, as much at least to some degree. So you have to know what the attending really wants and try to get real expectations for your specific scenario, not just what the formal curriculum says you're graded on. Some trainees start off with less insider knowledge, and this helps level the playing field. And again, we talked a little bit about the butterfly effect and first impressions and how it can amplify and spread. So that's just one example. I think even small tweaks with these things, I mean, that's what really makes the difference between somebody who is like okay and somebody who's great. Even some small tweaks here and there can have really big downstream effects. So that would be my case. Those are my major cases for why I think this hidden curriculum is really important. Okay. And finally, acknowledges that a lot of what we can do cannot be conveyed in writing. Okay. So we'll just go through these, and while we wrap up, what are the major four types of curricula? And it's formal, informal, null, and hidden. Formal lectures on professionalism mostly offsets the effects of observing unprofessional behaviors. That was false. Which of the following are different types of mentorship? Formal or informal, challenge or supportive, peer versus superior, research, or all of the above? Was all of the above. Who spearheaded the first modern U.S. surgical residency? Well, Osler was also at Hopkins, and he was in internal medicine, so close, but not quite. Charles Mayo, no. Walter Dandy was actually a protege of William Halsted, but it was William Halsted. What percentage of the subjective performance evaluation is noise, according to Kahneman et al.? That's 75%. We learn more from our own failures and observing those of others. It depends, because often we don't. If we deploy defensive ego defense mechanisms, then we don't. Which of the following methods is generally considered an effective learning technique? Well, rereading material and highlighting books are generally fairly passive. Mnemonic use is not meaningful. Content creation is covers more of the basis of the traits of effective learning that we talked about. Generational perceptions, which I made the case are really important, are influenced by which cognitive bias? Dunning-Kruger effect or overconfidence bias? No. And by the way, the Dunning-Kruger effect has been partially disproven. It's partially a statistical oddity, but we'll leave that for another time. Fundamental attribution error, where that's not it either. That's where you think if you make for example, if you make a mistake and you do it yourself, you attribute it to the circumstance, but if somebody else makes a mistake, you attribute it to intention. That's not it. Hindsight bias, close, but not really, thinking that you could have predicted an outcome prospectively, but looking at retrospective, that's not it. It's the illusion of moral decline. And that's where you judge people in the younger generation by your current self, not your former self. What percentage of US students have a physician parent? Closest answer here is 25%. Which of the following is usually most effective in gaining access to hands-on procedural experience? Select all that apply as a trainee. Planning the procedure ahead of time as if you're a sole operator, yes. Bringing notes that demonstrate that you have planned the procedure, yes. Knowing the evidence, indication, and alternatives of the procedure, definitely. Assuming your chief attending consents your level of interest, no. So that's another thing I didn't mention, but sometimes I hear attending say, well, he didn't seem interested, so I didn't let him or her do much. But it's like, did you ask? No. They just look and they just make an assumption. And I think it's wrong, but that's really what happened. So I wish they would do it differently, but as a trainee, you have to be proactive to show that you're interested. The sum percentage of perceived effort of those on a group project, according to Harvard Business Review, is closest to 140. Remember, it's 139%. The NEL curriculum refers to topics that are intentionally left out, not the others. The hidden curriculum has a well-established consensus definition? No. Was this first described in medical literature? No. Is a sneaky way educators try to trick and test you? No. Was first described by name in 1960s? That's yes. The difference between an average writer and a great writer is most likely natural gift. I would say no. I mean, it probably helps a little bit, but no. Years of experience in medicine probably helps a little bit, but no. Doesn't matter that much in medicine. Wrong. Attention to editing, I think, would be the best answer. On clinical rotation, first impressions are quickly forgotten, less important than last impressions. Those are both wrong. Last impressions can leave a lasting impression, but they're not as impactful. Reliable ways to determine somebody's trustworthy, wrong. Again, sociopaths make good first impressions. Disproportionate influencers on the opinions of others, yes, through that excessive coherence, cognitive bias. So that's my whirlwind of information for you. I know it's a bit academic, but I personally think this is what's useful in medical training, based on 2.5 years of researching the topic and 15 nearly 15 years in practice, and a lot of it with educational roles here in neuroradiology. Of course, I couldn't do this alone. I had a lot of help with a lot of the chapters from all the people listed here. So I don't think any of them were able to tune in today, but special thanks to all of them. And thank you for listening today. I really appreciate your time and attention.
Yeah, thank you, Vance. Thank you for taking your time. And I can't believe you wrote that while maintaining a practice. It's
Mm.
truly incredible. And we have some active panelists here, I'm sure, that want to make some comments or ask questions. Victor, why don't we start with you?
Thank you, Professor Lehman. Really interesting, but as a matter of fact, it's really, really complex to understand all of these topics. So I think for me, I need to listen and listen and listen in order to understand in a better manner. So congratulations for talking about this, for me, difficult topic, but very interesting. Thank you so much.
Yeah, no, thank you for the comment and feedback. And this is the first podcast talk I've given since I've written the book. So they're probably it is a complex topic, so there's no way around it. And I try to take a comprehensive view, but hopefully there's some ways I can try to simplify it a little bit more in the future or tie things together. But yeah, thank you for the comment.
Very good. Uday, do you have a comment or question?
That was a very wonderful presentation, and so really emphasized the role of good mentorship and how to go the relationship between the sponsor and a mentor and how to establish that mentorship and how to recall things and to educate oneself by content creation. And I really appreciate the talk. Thank you.
Yeah, well, you're welcome. Thank you for tuning in. I appreciate your comments.
Yeah, Uday is from India. Bhopal, is it Bhopal, Uday?
So, Merit, I'm a neurosurgeon, so
Oh, okay.
Merit.
Okay, yeah, Victor's from Mexico City.
Yeah.
Aka, go ahead, Vance.
Oh no, it's just great to have people from, and that's one thing I love about the channel, just from so many different areas. And I feel like this topic is, I center in the
Universal,
United
yeah.
States, but it's just useful because it's trying to level the playing field for people of all sorts of different backgrounds, So yeah.
Okay, Ata, you have your audio hooked up okay? Go ahead, Ata. Technology. I'm sure Ata has a lot of questions. Ata, if you can't, you can text your questions or comments. You don't have to necessarily speak.
Let's see if I get
I talked to him before, and I know he wanted to make some comments.
it.
Ata, going once.
Oh.
Unfortunately. Okay, I guess Ata will have to somehow get in touch with you. I'm sure he'll come to the next couple. I'd like to thank you again, Doc, for the time, and thanks for the panelists for coming. And we'll talk about when we're going to do the next one. Just an interesting area. I love education, obviously. I've been doing this for 8 years. Just education, and I commented to you before, for some reason, neurosurgery has picked up online education more than the other professions. Because I tried doing them in other areas, but there just didn't seem to be the deep interest that the neurosurgery community has. So I applaud the neurosurgery community for accepting this platform. Okay, we'll be in touch. And thank
All
you
right.
very much, Vance.
Yes, thank you. Yeah, bye now. Thanks.
Okay, I'm going to turn it off here, and you can stay here for a second here. Just turning off the live stream. Okay, let me stop.